Hello and welcome back to Personalizing Treatment for Patients with Non-Small Cell Lung Cancer, presented by Albert Einstein College of Medicine of Yeshiva University at OMED Live. You are tuned into today's second session titled Advances in Targeted Therapy for Non-Small Cell Lung Cancer. My name is Dr. Ajit Paintal, and I'm an assistant professor in pathology at Northwestern University at the Feinberg School of Medicine. Today's session is a live, interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to welcome back Dr. Jyoti Patel, who will lead this session. Dr. Patel is an associate professor of medicine at Northwestern University, Feinberg School of Medicine, and serves as the chair for this CME program. Jyoti, thank you for joining us today. I'll now hand the program over to you to begin our discussion.
Great, thanks so much. So this is dovetailing on sort of the tremendous work you presented about biomarker testing. I'd like to talk about how we actually integrate that information for our patients. So as you know, lung cancer remains the leading cause of cancer-related mortality in the United States. And the unfortunate part is that over 70% of patients present with locally advanced or metastatic disease at the time of diagnosis. About 40% of patients present with adenocarcinoma, and about 30% of patients present with squamous cell carcinoma. Now, clearly there has been tremendous progress since the 1970s. Multiple meta-analyses have demonstrated that chemotherapy improves quality of life, symptom burden, and overall survival compared to no chemotherapy. And consistent work with single cytotoxic agents and then modern doublet chemotherapeutics in the 1990s demonstrated consistent improvements in response and survival. But really, in this past decade and a half, we've made tremendous progress. Now we know that certain patients who have oncogene-addicted tumors can, even though they have metastatic disease, can enjoy unprecedented 2-year survivals of over 60%, in contradistinction to where we were in the 1970s, where virtually no patients with metastatic lung cancer were alive at 2 years. So although these steps seem small, I'd encourage you to remind yourselves that they are cumulative and build upon each other with slow and steady improvements. So the seminal trial that I think laid the groundwork of modern oncology is Joan Schiller's trial 1594, and this was an ECOG trial, and the largest at its time, sort of looking for a standard regimen based upon all the newer cytotoxics in the 1990s. This 4-arm trial demonstrated that there's really no difference in efficacy between these regimens, and carboplatin and paclitaxel became the standard regimen based primarily upon toxicity. Unfortunately, median survival was just over 8 months, and it was poor. Patients were unlikely to live beyond 1 year, and even though we had made great strides in introducing some of these drugs, patients certainly were not living well with their cancer for long. That real paradigm change came, though, from that trial in which felt that there was really no difference between drugs, no difference between patients, and we really looked at it as a monolithic disease in which we empirically treated based upon physician comfort with a particular regimen or patient preference about alopecia or neuropathy, to a much more cognizant approach in which treatment's been personalized, and it's really based upon histology, molecular biology, and then patient factors such as performance status and age. We've really come to a new era in which we've gone from thinking of lung cancer to thinking of lung cancers, and each of these diseases are unique, not only by their molecular biology, but also in each patient. And this is reflected in what we think is appropriate first-line treatment for patients with metastatic disease. So these are the NCCN guidelines, and as Ajit eloquently explained, the first thing we do is establish histologic type. Based upon that, we do EGFR or ALK testing. Based upon that, treatment is allocated such that patients who have a wild-type tumor are relegated to cytotoxic chemotherapy that's intravenous. If patients have a particular and discrete oncogenic driver, such as EGFR mutation positive or ALK translocated positive, oral tyrosine kinase inhibitor therapy is the primary treatment. But even within those patients who don't have EGFR or ALK positive tumors, there is a wide sway. We call it doublet chemotherapy, but we've learned in recent years that bevacizumab and pemetrexed have a prominent role for some of these patients. So the first trial to really demonstrate that the targeted therapy could look like cytotoxic therapy was a Scagliotti study. And this was, at the time, the largest trial done in metastatic lung cancer. And it was designed as a non-inferiority study of cisplatin and pemetrexed versus cisplatin and gemcitabine. And the trial met its primary endpoint, and overall survival was equivalent at 10.3 months for both arms. But in a histologic subset analysis, overall survival in patients with adenocarcinoma or large cell carcinoma was significantly better on the pemetrexed than the cisplatin and gemcitabine. Now, cisplatin and pemetrexed is an antifolate, and it is felt that perhaps high levels of thymidylate synthase expression in squamous cell carcinomas makes that tumor type relatively resistant. And based upon this study, although pemetrexed had initially been approved for all non-small cell lung cancer, based upon this study, the FDA recommended that only patients with non-squamous non-small cell lung cancer receive pemetrexed in the front line setting, in the second line setting, or in the maintenance setting. Another targeted therapy that has significantly altered our approach to lung cancer is bevacizumab. So vascular endothelial growth factor is pivotal in carcinogenesis, in feeding tumor cells, but also in metastasis. And so this trial was designed to see if the addition of antibody to VEGF, bevacizumab, could improve efficacy of chemotherapy. And so this trial, Alan Sandler's 4599, built upon the ECOG standard regimen of carboplatin and paclitaxel versus carboplatin, paclitaxel, plus bevacizumab. Now, importantly, patients in the study had a non-squamous histology. And what we have found is that patients with squamous histology have an increased risk of pulmonary hemorrhage with bevacizumab. So this was very clearly a safety signal, because that hemorrhage could be fatal. Clearly the tumors responded, but in the phase 2 trials, approximately 30% of patients with squamous cell tumors had high-grade toxicity from hemorrhage and even death. This trial hit all three endpoints that we care about. It improved a response rate with the addition of bevacizumab, it improved progression-free survival, and it improved overall survival. For the first time, adding a targeted agent to chemotherapy improved survival over sort of that landmark of 12 months, over 12.3 months. It's 4 months longer than what we saw with just standard chemotherapy in 1594. So I think this is a significant improvement. These two drugs, pemetrexed and bevacizumab, are what we consider standard cytotoxics. There are very few. Histology predicts efficacy and safety, but there is no biomarker for bevacizumab in which there's a prediction of whether patients will or will not respond. Based upon the pemetrexed and bevacizumab data, we developed a phase 3 trial looking at integrating pemetrexed with bevacizumab, and we compared this with the 4599 regimen. And again, this was a population that was very similar. It was a non-squamous population, again, based on pemetrexed and bevacizumab. And this trial was set to be a superiority trial, and unfortunately it was negative. There was no improvement in the experimental arm of carboplatin, pemetrexed, and bevacizumab over standard carboplatin, paclitaxel, and bev. The hazard ratio you see is 1. However, there were differences in toxicity. So patients with pemetrexed, for example, had no alopecia or much less neuropathy. Patients who were treated with paclitaxel had less fatigue and myelosuppression, particularly thrombocytopenia. So this